Welcome back to The Explainer. I'm incredibly excited to guide you through today's session. If you are prepping for clinical boards, or maybe you just need a razor-sharp refresher on pharmacology, you're in exactly the right place. Today we're putting on our clinical detective hats for a rapid-fire review focused entirely on high-yield antiviral resistance and absolute contraindications. We aren't going to waste time on the basics you already know. Instead, we're hunting down those heavily tested red flags, the tricky drug interactions, and the specific mutation pathways that examiners absolutely love to go after. So grab your notes, lock in, and let's get right to it. Here is the roadmap for this explainer. First, herpes viruses, then respiratory infections, hepatitis B, hepatitis C, and finally, COVID-19. Section 1. Herpes viruses, resistance, and renal risks.
Okay, let's start with a classic showdown between our two main first-line drugs, and specifically their activation mechanisms. Acyclovir, which we use for HSV and VZV, requires activation by viral thymidine kinase. It's a deoxyguanosine analog that only gets activated inside infected cells. On the flip side, ganciclovir is our go-to for CMV, and it relies on a totally different enzyme, the CMV UL97 protein kinase. Exams love to test this specific nuance, because if a virus mutates its specific activating enzyme, that first-line drug becomes utterly useless.
Let's simulate being pimped on rounds for a second, just to test your active recall. This is the ultimate, most heavily tested CMV resistance trap. Imagine your immunocompromised patient has CMV. The lab comes back showing the virus has a mutation in UL97, meaning of course ganciclovir is out. But it also has a mutation in UL54, which actually alters the viral DNA polymerase itself. So what's your rescue drug? What is literally the only drug left in your arsenal?
The answer is foscarnet. That is your sole rescue option here. When you see that double mutation of UL97 and UL54, reaching for foscarnet needs to be an automatic reflex. Why? Well, unlike acyclovir or ganciclovir, foscarnet doesn't require any viral kinase phosphorylation to work. It acts directly. Because it doesn't need that viral kinase, it just bulldozes right past those mutations. It's a pyrophosphate analog that directly binds and blocks the viral DNA polymerase. But this immense power comes with a toxicity profile that will make your patient's kidneys beg for mercy. Foscarnet essentially acts as an electrolyte chelator in the body. You're going to see severe hypocalcemia, hypomagnesemia, and hypokalemia. And these aren't just minor little lab abnormalities. These electrolyte drops are so steep they can lead straight to severe arrhythmias or even seizures. Administering this drug requires absolute precision. Get this. A staggering 30% of patients on foscarnet experience significant nephrotoxicity. This massive 30% risk is exactly why the clinical protocol includes mandatory IV saline hydration before and after every single dose. It's totally non-negotiable if you want to protect the patient's kidneys. So if you see foscarnet on an exam, immediately look for that hydration requirement and those plummeting calcium and magnesium levels.
Before we leave herpes viruses, we got to talk about the other major rescue drug, cidofovir. Like foscarnet, it's used for resistant strains, specifically when there's a TK or UL97 mutation. But keep in mind, it doesn't work if there's a UL54 mutation. Cidofovir is a deoxycytidine monophosphate analog, and it causes incredibly severe nephrotoxicity. The absolute key here, the highest yield fact to remember, is that cidofovir must be co-administered with probenecid and IV saline. That blocks its active tubular secretion and protects the kidneys. Basically, no probenecid, no cidofovir.
Let's move on to Section 2, Respiratory, Flu, and RSV Facts.
Let's break down our three main flu fighters. Oseltamivir and zanamivir are your classic neuraminidase inhibitors. They block the cleavage of sialic acid, physically preventing the virus from releasing from the infected cell. Oseltamivir is oral, and it's notably the drug of choice for pregnant and hospitalized patients. Zanamivir acts by the exact same mechanism but is delivered as an inhaled powder. Then we have baloxavir, which operates entirely differently. It inhibits cap-dependent endonuclease, blocking viral mRNA synthesis, and the best part is it only requires a single oral dose.
Okay, pause right here and burn this contraindication into your memory. Because zanamivir is an inhaled powder, it is an absolute contraindication in patients with asthma or COPD. Giving it to these patients carries a massive risk of severe, potentially fatal bronchospasm. Examiners love to sneak a history of mild asthma into a clinical vignette about the flu. If you see asthma, zanamivir is off the table. That is a guaranteed exam question.
As for the newer drug baloxavir, watch out for this highly testable interaction. Because it's a single-dose oral drug, absorption is absolutely everything. If your patient takes it with dairy, calcium supplements, iron, or antacids, the drug chelates and its clinical levels just plummet. It's a simple counseling point that makes for a perfect multiple-choice distractor.
Section 3. Hepatitis B, beating viral resistance.
So why isn't the older drug, lamivudine, our first-line defense anymore? Well, the resistance rates tell the whole story. It was the first oral HBV agent, but the virus learned to outsmart it incredibly fast. By year 1 of treatment, you're looking at a 30% clinical resistance rate. By year 5, a massive 70% resistance. We are practically selecting for mutant strains. This created a desperate need for higher barrier agents.
Enter the high-barrier drugs, starting with entecavir. It has such a high barrier to resistance because it literally forces the virus to overcome a triple blockade. It inhibits HBV priming, it blocks reverse transcription, and it stops positive strand synthesis. Just note, for maximum absorption, the patient has to take it on an empty stomach, and if they have prior lamivudine resistance, you actually need to double the entecavir dose from 0.5 to 1 milligram a day.
Our other first-line champions are the 2 formulations of tenofovir. Now, both of these boast virtually zero clinical resistance, even after 8 years of use, which is just mind-blowing. But they differ wildly in their toxicity profiles. Tenofovir disoproxil fumarate, or TDF, has a notorious reputation for causing nephrotoxicity, specifically Fanconi syndrome and renal tubular acidosis, along with significant bone loss. Tenofovir alafenamide, or TAF, was developed to deliver the drug more efficiently to lymphoid cells, resulting in far less nephrotoxicity and fewer bone effects. Knowing the difference between TDF and TAF toxicities is absolute gold for the boards.
Section 4. Hepatitis C, cures and contraindications.
95 to 99%. Let that sink in. That is the sustained virologic response, or SVR rate, with our current direct-acting antivirals, or DAAs. Achieving SVR means undetectable HCV RNA 12 weeks after finishing treatment. Functionally, that means a cure. We can achieve a real cure for nearly everyone with a simple 8 to 12-week oral regimen.
But you can't just hand these drugs out blindly. There are some absolute red flags you cannot miss. If you're prescribing sofosbuvir, an NS5B inhibitor, you absolutely must check if the patient is on amiodarone. Combining them causes severe, potentially fatal bradycardia. For protease inhibitors like glecaprevir, they are completely contraindicated in patients with decompensated cirrhosis, so Child-Pugh class B or C. Finally, if you're looking at older therapies like pegylated interferon, you have to watch out for decompensated cirrhosis as well, but also autoimmune thyroiditis. Interferon can just wreck the thyroid. Seriously, commit these interactions to memory.
Finally, Section 5. COVID-19 Crucial Drug Interactions.
When we talk about outpatient COVID-19 treatment, Paxlovid is front and center. But remember, Paxlovid is a combination of nirmatrelvir, which is the actual antiviral protease inhibitor, and ritonavir. Ritonavir is only in there as a pharmacokinetic booster. It's a really potent CYP3A inhibitor. And because it shuts down CYP3A, it causes major, dangerous drug interactions with medications metabolized by that pathway. You must immediately dose adjust or completely avoid co-administering with statins, immunosuppressants like tacrolimus and sirolimus, and colchicine. Ignoring this can lead to severe toxicity.
And finally, if your patient is hospitalized and on oxygen, they're probably getting IV remdesivir, an RNA-dependent RNA polymerase inhibitor. Here is a quick, high-yield pharmacology interaction. Do not give remdesivir with hydroxychloroquine. The sources clearly state that hydroxychloroquine causes in vitro antagonism of remdesivir. It's a classic distractor on modern exams that tests whether you're keeping up with the evolving pharmacology.
And that's a wrap on our rapid-fire word tour. We've navigated the heavy renal toxicities of Foscarnet, dodged the asthma contraindications of zanamivir, beaten hepatitis B resistance, cured hepatitis C while avoiding deadly bradycardia, and mastered Paxlovid's CYP interactions. By structuring your learning around these high-yield pathways and absolute contraindications, you are perfectly positioning yourself to excel. But as we deploy these increasingly advanced targeted weapons, it leaves us with one terrifying question. What will be the virus's next move in this endless evolutionary arms race? Keep studying smart, and I'll catch you in the next explainer.